Hello, this is Kamran Bhopal again with another video on emergency scenarios, and this is emergency scenario with bladder injury and ureteric stone. So this is a scenario which is also a prioritization scenario. So the question comes as you're an ST3, you've got the first patient who's got an 8mm stable VUJ stone. So when I say stable, that means the patient's not septic, the patient's reasonably stable, his hemodynamics are stable. So 8mm stable VUJ stone. There's a bladder injury whilst doing a C-section and someone's called you about it from the gynecology theatres, and there's a 30-year-old with 12 hours history of testicular pain. So how would you prioritize this scenario? The way I would answer it is there are multiple urological emergencies in this scenario, and I will rationalize my skills and my team skills and limitations to prioritize this patient safely. I will first of all prioritize the 30-year-old with testicular pain, as this might be a testicular torsion. I would call my consultant and request him to look at the bladder injury and call the theatre to get the equipment ready. I will call ask my F1 to go see the stable 8mm VUJ stone, and I will tell him the things to look out for and call me back, and I will review this patient after him. So now the next question comes as, okay, what is the kit that you will ask for bladder injury in theatres? So you should learn this by heart. So you need 2 ovicral sutures, 16 French urethral catheter, methylene blue dye, and non-suction drain. And then you also need a standard cystoscope set and stack, guide wire and a ureteric catheter, 50-50 contrast, omnipaque with saline, and a radiographer with a C-arm. So the first 4 are to repair the bladder injury. The next 4 things that I've mentioned are to look for any concomitant ureteric injury. So how will you manage the bladder injury? So this actually is explained in different books. The best one is the Bowes consensus. There's a few extra steps in the Bowes consensus, and I think you should mention them, and that actually tells your experience in urology. You will understand there's a few things such as non-tension repair, interposition of the omentum, consideration of suprapubic catheter in significant injuries, non-suction drains, these sort of things. If you mention it, and the closure of the bladder, how you would do that, for example. If you've read that Bowes consensus guideline, you will be very clear about how you manage a bladder injury and how you repair a bladder. Because, for example, you can close it with as a mass closure with a single layer technique, or dual layer technique with the mucosa and muscle layer separately closed. And you can also do continuous and interrupted, or a mixture of both sutures with 2 ovicral. And as I said, consideration of suprapubic and larger injuries, methylene blue stretch test, etc., etc. But so I'll now say my answer. But it's good to go through that Bowes consensus document, because that was very helpful. So the principles of management are urethral catheterization and then mobilization of the bladder for tension-free repair and assessment of injury. Absorbable sutures, 2 ovicral, can then be used to close the bladder without tension in a single or a 2-layer technique, closing the mucosa and the muscular layer separately. This can be done in an interrupted or continuous manner and ensure the bladder is watertight by doing a methylene blue stretch test with 300 ml of saline with a few drops of methylene blue mixed in it. Consider an SPC for complex injuries and leave a non-suction pelvic drain, and interpositioning of omentum should be done. Bilateral retrogrades to rule out concomitant ureteric injury should be performed, and catheters are to remain for at least 2 weeks till cystogram is done and shows no leak. So these are the things that, if you mention in your bladder injury repair, they know what you're talking about this mental interposition and suprapubic catheter insertion in larger injuries, how you would close it, how you would stretch test it, when you would remove the catheter. So this is all can be a big thing, and this is quite common because bladder injuries do occur, and if you're aware of these things, you will get some brownie points over people, because in the interview questions and banks they have not mentioned it in this much details, so these specific points, and you will be able to gauge them when you're looking up in the notes. So then there's a question about the testicular pain guy. The 30-year-old has got a past medical history of recent chlamydia, progressive worsening over the last 12 hours, erythematous, normal lie, and the pain is controlled. What is your differential diagnosis and management? So differential diagnosis, we've got epididymoarchitis, although torsion needs to be ruled out, scrotal abscess, inguinal hernia, and trauma, hematocele, and rupture, etc. How would you manage this patient? So since history has been taken and examination performed, I would discuss this case with my on-call consultant. If there's any suspicion of torsion, I would explore him. If there's any signs of abscess, I would do an incision and drainage. If the patient is septic, I would ensure that the sepsis 6 protocol is in place. If it is epididymoarchitis with no abscess, I will treat him with antibiotics according to the local guidelines, given no allergies. Usually this is IM ceftriaxone 500 milligrams as a stat dose and doxycycline 100 milligrams twice daily for 2 weeks. After that, ultrasound testes within the next week to confirm diagnosis. So this is sort of the things that they are wanting to listen from you. The next question is about, okay, you've got a patient who's got renal colic. The patient who had the renal colic with the 8 millimeter distal ureteric stone, the patient's got persistent pain. What will you do? So ensure adequate analgesia, including diclofenac 100 milligram suppository if there's no contraindication. If the pain is still uncontrolled according to NICE guidelines, he needs a primary ureteroscopy and laser stone fragmentation. If this is not possible due to equipment or theatre trained staff, I would arrange for a ureteric stent. And what if the pain settles? What will you do? So I will discuss it with the on-call consultant. If there's no red flags such as AKI, single kidney, sepsis, bilateral stones, the patient can go home with safety netting and a few options which we would counsel the patient about. Number one, we can look at conservative management and use the mimic calculator to calculate so say mimic calculator because mimic study is quite good. According to the position of the stone and the size of stone, it tells us the percentage of or chance of it passing spontaneously. So conservative management using the mimic calculator with a stone clinic follow-up appointment with a repeat ultrasound or x-ray, and use an for assessment. And then number two is hot ESWL. You can get an ESWL slot within the next week, and then or he can be brought back for a primary ureteroscopy in the next available stone list in the next couple of weeks. So these are different ways of dealing with the stable stone in which the pain is also controlled. So that's the end of another prioritization scenario, and I hope you've learned something from it. Have a look towards the very end. I would have done some extra questions which I've gathered, which are quite useful. And all the best, and hope you all get a national training number.